I'm your host, AJ Chen, co-chair of the Forum Organizing Committee. This is my volunteering work. And my day job is a consultant at Silicon Valley, specialized in learning health system. Today's webinar will be focused on an interesting topic, building new infrastructures for global learning health systems. After the routine welcome and introduction, we will hear a keynote from Dr. Robert Califf and then industry focus from Dr. Glasser. After that, we'll do Q&A. Please post your questions in the chat window as the presentation, during the presentation. And my committee colleague, Sophia Wen at Stanford will take the question, and then I will read out the question during the Q&A. Let's switch to Josh to give a few words. Josh?
Okay, thank you so much, AJ. One of the reminders I'll ask everyone, including myself, to remember to please mute yourself when you're not if you're not the active speaker. And I very much look forward to our discussion. I guess I really wanted to begin by thanking, first thanking really everyone who has come to participate in this meeting and in our meeting last December, and hopefully this ongoing dialogue, where we're really going to take the learning health community that was founded on the set of core values about a real vision for health that is, not a technology initiative per se, but about just changing the experience of medical research and of healthcare and health for clinicians and patients and public health professionals and communities and every other stakeholder group according to a set of values we all believe in. And I wanted to thank everyone for being a part of this dialogue around how we find the technology infrastructure to make that possible, and how we bring people from the tech communities, from the clinical communities, from the research communities and others together to really think about making that happen. So I am so grateful for everyone's participation. I wanted to also just thank the people who organized it. AJ, who is really envision this Tech Forum initiative in particular of the community and helped spearhead it. Sophia and the other volunteers who helped really make, Casey, the volunteers who helped make this happen. And then again, of course, thanking the speakers and Dr. Friedman, who's been a part of this, and all of you for being a part of this. And in order to, the whole point is growing the network beyond the folks that are, certainly the folks that I've met, let's say HIMSS and APHA and other conferences around learning health systems, and growing it to other tech people. So to help grow that, I really want to thank our folks at Stanford University, thank the folks at AMIA who've been helpful for many years, thank the folks at IBM Watson that have helped with the research, and then thank Stanford that has donated the Zoom technology to help beyond my limited Zoom that I have that I've given to the community. Thank the folks that have made this possible. So I will now turn this back over to AJ to continue with this program, but really thank everyone, and I look forward to a great meeting.
All right, thanks, Josh. Let me just give a quick introduction of the background for today's discussion. Learning Health System Vision was created by National Academy of Medicine about 10 years ago. It is in early implementation phase by the US Health Department, as far as I can tell. To help accelerate the implementation, we have just started this new initiative to create an ongoing forum for bringing together industry innovators and academic researchers to discuss learning health system technologies. Learning health systems will be built on technology infrastructures, which covers many layers of technologies. Briefly, in my simplified view, at the top of the technology infrastructure, we need new system level evaluation technologies such as pragmatic clinical trials. The application layer has all the bells and whistles, such as decision support systems, learning cycles, machine learning and artificial intelligence, etc. happen at the knowledge layer. Data standard and interoperability layer will enable new knowledge discovery and dissemination. At the bottom is the computing layer including. Enough for the background. Now let's hear the keynote speech from Dr. Robert Califf. It's my honor to introduce Dr. Robert Califf from Google and Verily, where he's the head of clinical policy and strategy. Dr. Califf serves as an adjunct professor at Duke University. Most notably, Dr. Califf was former FDA Commissioner. He's well-known physician and researcher and a visionary innovator in healthcare. We're so thrilled that Robert will share his vision of learning health system infrastructures and what Google is doing about it. Let's welcome Dr. Robert Califf. Robert, go ahead. Let me stop my sharing.
Thanks.
You can share
Okay,
your screen.
can you hear me okay?
Yes.
All right, let me see if I can get the slides to come up here. All right, first of all, thanks for the opportunity to talk and also to learn. I'm always worry in an audience like this that I'm going to be wasting people's time because I'm not a technical person. What I'm going to talk about is really maybe orthogonal to what you laid out so nicely in terms of the layers, and speak to the purpose of what we're trying to do. And I'm not going to talk about specific technologies or products at Verily or Google Health, but maybe give you insight into what we're thinking that needs to be accomplished with the products. And I really look forward to the discussion, which I'm sure will be interesting. And I had to pull up the slide that I had a call with you all and with Chuck a couple of months ago or last month, and I have to pull up your classic slide because it's very similar to the way I've thought for a long time since being exposed to all this in the late 1970s with Eugene Stead back in the very early days of any sort of computing in medicine. And, it was immediately evident at the time, almost nothing was in a computer. It was almost all on paper. And it was amazing as a medical student to see the difference when you could record some things and then follow people up and see the vast difference between the impressions that clinicians had and the truth from the data that you could fairly easily collect. The problem that happened with me is that we had one specific application, coronary artery disease in the early days. It seemed so obvious this should catch on that I was off by about 4 decades in terms of when the learning health system could possibly become a reality. And frankly, that's the reason I'm at Alphabet. I think it is, to do this right, really is going to require the type of computing which is now available. And I don't think the limitation is in any way the computing at this point, which is an enormous change. The limitation is our culture and the structure of what we do and how we think. I'm going to race through some slides just to, you all will know this already, but I've learned over the last couple of years that it's very hard for people in the US to absorb how pathetic our system actually is in terms of health outcomes and some of the underlying issues that I think are compelling to say we'd better do something different, so we're different or we're headed for a disaster. This is a look at life expectancy and then projected on out. And, you'll notice that for men and women, life expectancy was increasing up until a bit after 2010. This is not all an effect of the Trump administration. It was actually starting when I was in the Obama administration that life expectancy is in a negative trajectory. And of course, with 2020, with the pandemic, I think the best estimate is we're going to have a 2 to 3 year drop in life expectancy in 1 year, with right now about 1 out of 850 Americans having died from COVID-19. But that's only the gross overview of the problem. if you look at it county by county, you get a very different view of what's going on. And I would say that almost everyone on this Zoom call is most likely in a blue area depicted here. This is from the IHME group in Seattle, now famous for its better or worse COVID projections. But this group was funded by the Gates Foundation to help developing economies develop policies based on data and models. But they've turned a lot of attention to the US lately because we're like racing to become a developing economy by the way our health statistics look. And so when you look county by county at life expectancy, there are vast differences. People that live on the coast or in university towns are living like Scandinavia and Japan. People that live in the middle of the country and in rural areas are quickly devolving. And these differences are on the order of 10 to 20 years. And in fact, if you take almost every university town and go 3 counties away, you'll see a vast difference in life expectancy. Even San Francisco, if you go to Lake County, there's a 12-year difference in life expectancy. But to make it even worse, the direction of the change is dramatically widening. So the areas that were doing well already are doing better and better, and the areas that were doing worse are evolving in the wrong direction fairly rapidly. The biggest decline in life expectancy is white men living between Oklahoma and West Virginia, something that's not talked about a lot, but fairly obvious. And in an analysis which is under review right now that I was involved in, if you look at change in life expectancy and voting by county, Democrat or Republican, the correlation is about 0.78. There is a dramatic political difference in these life expectancy differences, reflecting very dramatic cultural differences. Now, if you go to the next level and look underneath these differences, and it's really kind of the main point what I want to say today. And everyone knows this now. This is all rooted in social determinants. So if you look at the biggest predictors of life expectancy and change of life expectancy, it's wealth, education, race are the key factors. Sex is also important, but people don't talk about it much. Men live in the US on average 5 years shorter life expectancy than women, and the difference right now is diverging somewhat. There's more being written about this now. But if you look at the second tranche of factors, what's the biology and behavior underneath this? It's not mysterious. It's things that we know a lot about. Obesity, diabetes, hypertension, cigarette smoking, etc. These are things that are modifiable, deeply embedded in culture. The good news for clinicians is that at least physicians per 1,000 population comes out as an independent positive factor, but it's pretty small compared to these social determinants. And one of the biggest differences that's evolving very rapidly is rural versus urban America. Here you see the divergence in life expectancy. And if you'd asked me as a kid growing up in South Carolina in the 1950s, would people in rural areas be exercising less than people in urban areas? I would have said, that's impossible. How could that be? But it's a very big difference now just in daily exercise activities, not to mention drug addiction, overdose, and suicide deaths. So we have big differences here according to where you live. And then if you say, what does this mean in terms of our country versus other high-income countries? You'll notice all the other countries are sort of on an upswing over the last 3 decades. Some leveling off in a lot of the countries, but we are the unique outlier among the high-income countries. We're in last place and rapidly diverging in the wrong direction. So I often hear people in universities talking about learning health system as something of, we have all this wonderful stuff, let's pull it together. I'd say we have warning signs that we're going down the tubes and we better do something differently. Now, this is one of my favorite slides. It's used over and over, but I stole this one off of Twitter, all marked up. And the point of the person that marked it up was, really a response to people to say, well, the reason we spend more and have a shorter life expectancy than every other high-income country in the US is because we have a more heterogeneous population. We're different. But if you go back to the lower left-hand corner, we were also more diverse and heterogeneous than the 70s. We didn't look that different. The two big differences are healthcare as a right and a primary care system. So it's fair to argue these other countries don't have wonderful learning health systems by and large. They just do the basics well. It's fair to argue we don't need fancy learning health methods to catch up, but we live in America, so we would never do what's obvious, and we're going to have to do something that's a little more fancy if we're going to make it work. And then finally, in the background, I just want to, again, make the point that everything I've shown you has an enormous magnifying glass on it now called the pandemic. All of these disparities, every single one of them is magnified dramatically by the impact of the virus and the effect that it's having on populations, not only in the death and disability due to the virus, but also the pent-up lack of attention to the common chronic diseases, the pretty massive increase in addiction and drug overdose and suicide that's also occurring in these populations. All right, so I would argue, as now I'm fully embedded, working half-time at Verily, which is the biomedical regulated subsidiary within Alphabet, and Google Health, which is embedded within the mothership of Google, that, a way to deal with this dilemma support system, point out that we really are at a crossroads where we can either use this back and individuals to exacerbate the differences that already exist. Either one is entirely possible depending on how we handle it. So now I'm going to just go through at least the way I think about some of these issues. What should we do? The number one thing for me is when we talk about learning health, we shouldn't talk about healthcare delivery. We should talk a lot about what people do at home and the way they deal with information at home and how they actually learn and set their beliefs and expectations. We know, for example, that people routinely lie to their doctors about which medicines they're taking because they tend to like their doctors. They don't want to disappoint them and tell them they don't believe in the medicines that they're getting because they read something else on the internet. And so we got to improve access to high quality, reliable information as a really key issue. And the way I like to make this point is to show people this slide. Even though all of you are computer people, you probably recognize this. It's called a library. Many of the young people that we show this picture to regard it as some kind of a historical relic that used to exist, but they've never actually spent any time in one. But for someone like me, the master and mistresses of medical rounds were people who could go to the library, find the journal, make a copy of it on the Xerox machine and hand it out. But now this is what everyone in the world expects. And this is from 3 years ago. At the time, there were 16 million questions being answered every half a second, essentially in real time. So if we think our learning system is going to operate in the kind of cycles that we've grown accustomed to in the healthcare delivery system, I think we're making a big mistake. We still need those longer cycles, and I'm a strong advocate, for example, of particularly pragmatic trials. But embedded in here, we need a layer of information that's rapid, reliable, and useful. The second issue is home inversion. So just like people are going to be looking at their cell phones to get their information much more frequently than interacting with a doctor, we need to bring healthcare to them in the home. This is not anything unique. It's just that the infrastructure to really do it is finally really here. And the pandemic has given us the freedom to not be bound by a lot of the regulations that were making it very difficult to do. So, we're looking at an environment where you would only use clinic visits when they're actually needed. Most of what needs to be done in healthcare should be done at home or at work. And with the right digital backbone, community health workers can do most of the things that really matter. If you go back to the life expectancy slide, measuring a blood pressure, getting on the right blood pressure medicines, getting your LDL cholesterol right, and not smoking, those are the things probably much better dealt with more frequent interactions at home than with occasional visits to the clinic, trying to sit in a waiting room for half an hour and then spend 10 minutes with a doctor and then try to remember what the hell the doctor said as you're being shuffled out of the clinic by the administrator. But even when a clinic visit is needed, I think we all could probably agree this could be markedly enhanced by digital preparation before and after, because people don't remember much of what was said when they're in clinic, particularly if it's a serious problem that they're dealing with. They're going to need to be reminded when they're at home and educated in a different way. So we're constantly reminded of this, and COVID is probably the mega example. 400 billion downloads of information about COVID from search and YouTube. That's a number I still can't quite wrap my head around. And so people are asking about their health on the internet from home. And we're working hard to provide knowledge panels that are more authoritative. But the problem here in a learning sense is that, and I learned a lot about this at FDA, for example, with food labels, when you're trying to give one common base of information to 7 billion people speaking multiple languages at very different levels of education, this is something that requires a much more tailored system to the needs of the individual. So it's just giving you an idea of the kind of things that we've got to think about now. Depression is an example we've already worked on. So just to give you the basic scoop here, 300 million people have depression in the world. Only half of them ever get treated. Even in the US, it looks like it's an average of about 7 years from the time you can identify someone as being depressed based on their interaction with the internet and the time they actually get medical care. The treatment's not curative, but it's a chronic disease where the treatment is effective in reducing negative outcomes. So how do we help with this? You know, we made a meager start, but we did an experiment where we asked people, it looks like you're depressed and you're looking for information. Would you mind taking a survey? The survey is a medically validated PHQ-9. If people excuse me, if people answer question 9 positively, it means they're maybe thinking about suicide. So they get referred immediately to the National Suicide Hotline. But the rest are now in a bin of people with identified depression, many of whom have no medical care. And if we unleashed all these people on the mental health system in the US, you know what would happen. We even, in a study we're doing, and I'll pick on my 2 affiliates, Stanford and Duke, both Duke I take a lot of responsibility for. When we ask the question in a study, if we identify somebody answers question number 9 correctly, what do we do? And there was actually a view a lot of people had that we shouldn't ask the question because it would raise an issue that the health system couldn't handle just for people who are imminently thinking about committing suicide. So we got big issues to deal with, but some insights into at least how to get started. And then we got the healthcare team. Let's say we do everything at home we can. It is obvious that for the number of people with problems that we have and the massive amount of pent-up chronic disease care that's going to be needed when we get on the other side of the pandemic, there is no way to rely on the traditional healthcare system to take care of it. We need the healthcare system to function at the top of its game, and this is where a digital backbone could be very important. And we've at least come to the conclusion that most of the common chronic diseases have a common basis in behavior. No surprise here. What do you eat? Do you exercise? Are you addicted? Do you use tobacco? Are you on the right medicines for your disease? And are you taking the medicines assuming that you're on the right ones? And underlying all of this is a mental health construct where depression and anxiety are affecting about half of our population today. And it is just not even conceivable that the way we're currently delivering healthcare in a human way could possibly have the impact that's needed. And, you know, simple proof of concept is just look at diabetes and ask the question, where do people live who have diabetes? And then ask, where do endocrinologists live? The endocrinologists, like you and me, like to live with other highly educated people who have a good lifestyle and have similar cultural habits. But the people with diabetes are in all the other places. And so we've got to develop a system that uses a digital backbone to deliver the care to these people. We've learned a lot about this by employing AI. There's no question now that a simple cheap camera with AI can do as good a job as a fully qualified ophthalmologist in at least identifying that someone has diabetic retinopathy. But the problem that we've run into is that this is very inexpensive, could be massively deployed, but it doesn't fit in with the current healthcare system, and it's disruptive because we learned a lot of ophthalmologists spend a good bit of their day doing relatively easy exams on a high throughput basis. And what we need is for the ophthalmologists to be doing the treatments to prevent blindness out of those who are identified as having it. And the primary care systems typically don't have enough volume to justify putting the expensive cameras in. So doing this independently of the way the healthcare systems work is not going to do it. Then the next thing is coupling predictions with actions. And Dr. Stead used to say, do you want to know if it's the probability of rain today if you have to go outside anyway and you don't have an umbrella? And I think we are rapidly approaching the stage, and many of you are involved in this, where we can predict almost anything and quantify the operating characteristics of the predictions. But the missing information, by and large, is what do you do based on the prediction? An area that I've been fascinated by being a cardiologist is using digital streams in surgery, where the theory is there's no reason a rural surgeon should not be able to have the world's experts scrub in if they're doing an operation they hadn't done many of, but they have to do it because it's an emergency and there's not time to move the patient. And it's also possible that you could use machine learning if you had a lot of operations digitized to help the surgeon not do stupid things in the operating room. And you know, this is moving slower than I would like, but I think it's within sight that systems like this will be available. And then there's routine decision support, which this is just from an example in Google Health that played out in the NHS and the VA system. And it's exemplary, I think, of a lot of things. First of all, the healthcare system, EHRs that we currently have, you all are all experts in this. It just can't handle right now the number of things for which warnings would be useful if they could be organized in the right way. In this case, the question was, could you identify people who are going to develop acute kidney injury well ahead of time? And the answer is you can. But then what happened was, the question then is, what do you do about it if you know it's likely to happen? And you know, what I came away with was this is the ideal way to configure pragmatic randomized trials, because what you now have is a clear inception time where someone has a high risk. No one knows what to do. There are ideas and there are new therapies being developed. Let's get the trials done quickly and measure the outcomes in a much less expensive automated fashion. And here, just for fun, I went back to, you know, Bill Stead. And one of the main things we got to do is to winnow this information down to something that's humanly absorbable, because the amount of incoming information is so much greater than what the human brain can deal with. And then finally, you know, this obviously means we got to do a better job of ingesting and curating data. We're doing a lot of work on this, both at Google Health and at Verily. I've been very involved since before Verily was formed in the baseline project. And the simple concept here, which is not so simple to do, is to imagine your health like maps. You all probably all remember when you wanted to go somewhere, you got in a car, you would start driving. If you felt lost, you'd have to pull over to the side of the road and pull out a map to figure out where to go and then try to remember what the map showed. Now you just start talking to your cell phone or to your car and it tells you where to go, because all the roads in the world are mapped, and AI is being used every second, and your preferences are being absorbed to help you get to the place you want to go in the way that you would like to get there. So the question is, can we devise a map of human health which allows people to navigate? And obviously this is much more complicated than roads. A lot of types of data. Many of you are involved in trying to put these kinds of data together. Just want to make the point we're working there too. And then finally, the last point, I do think that the concept of precision medicine and precision public health is extremely viable. There was in the intro, there was a discussion about learning health system, lower costs, better outcomes. You know, we're operating on the 4-quadrant, the quadruple aim concept, but my observation in the American system is that better outcomes almost never really comes up in the discussions with health systems. It's all about trying to lower costs, and the assumption that if you meet quality metrics that you're ergo going to have better outcomes. And I'm seeing a lot of teaching to the test on quality metrics without a true learning approach to developing better outcomes. And often these quadrants are not solvable optimally by the same interventions. That is, there are clearly better outcomes that can be achieved that raise costs. You know, that's been true forever. It's still true today, but you rarely hear discussions about this when the big contracts are being made between health systems and analytical industry. So I want to just raise one last concept related to this. If you're like me, you get up every morning and look at COVID tracker or something like it. The good news actually today is this is before everything started going the right direction. It's moving in the right direction quickly now. But it's also the case that by hook or by crook, the world has put together information at the level of the state, but also information at the level of the county and the local hospital that tells you how many beds there are, how many people are in the beds, how many have COVID, how many are in the ICU. This is readily available information now if you're highly expert at scraping the information together. And thank God the newly liberated CDC is now able to actually be the source of a lot of this information, which it couldn't do in the previous administration. But my question is, why don't we do this for every chronic disease, so that when we do interventions, we're not just talking about an individual patient or a patient panel or a health system, we're talking about the public health in real time. And it brought me back to a project we did in Durham about 12 years ago in the early days of using geospatial mapping. And the point of this project was to discover that, like all southern towns, Durham has railroad tracks, and different people live on each side of the tracks. And the name of the slide here, the right side of the tracks is the wrong side of the tracks in Durham. And the reason is because when you looked at emergency visits and use of the clinic, the people that lived in the university side, the right-hand side, made tremendous use of the clinics. The people who lived on the left-hand side of the tracks, actually it's reversed here, right and left, but people on the right-hand side of the tracks actually were in the poor neighborhood. They dominantly used the emergency department for their clinical care. And so intervening one person at the time without knowing the neighborhood characteristics and doing interventions without measuring the impact on the entire group is a big mistake. Now that we all have electronic health records, this could obviously be taken to any level that you want. One of the more interesting areas of COVID we're working on now is how low can you go in terms of density of population with wastewater analysis for viral variants. And you know, the problem is you can get down to the level of the apartment building or the household, but the big issue we got to work with there is privacy. So I'll stop there, and just with the point that we are entering the phase where technology is not the limiting factor for what we envisioned in the 1970s, but we have a lot of work to do to put the tools in place. But more importantly, something that you all are working on, get the culture right so that we do this in the right way. I hope this hasn't been too non-technical for you, but it's at least a view of the motivation behind what we're working on.
Okay. Thanks, Robert. Amazing talk. Well, you give us a huge background here. The digital backbone you mentioned certainly is, most of them are there already. We need to connect everything together and put it in use. And I'm happy that Google is doing a lot in this space. Is there a burning question here that Robert can answer quickly?
There are a few questions in the chat.
Yeah, let me just read out one question and then save the others for the Q&A session. Titus asks, how do you initiate and accelerate the culture change in health systems to move in the right direction that you just described? It seems that's the key challenge. Robert.
Yeah, I think we need to take what I think of as a sandwich approach, which within the health systems, we need to just keep hammering away at the principles and the values and the ethics of all this. But I actually believe the biggest factor is going to be changing the payment system. Health systems are heavily reimbursed still for doing exactly the wrong things. And, you know, I'm hopeful that there will be an effort by the new administration, as hard as it might be, to move to value-based care with population health being a key parameter that's measured. I'm 100% convinced that if you told, for example, the Duke Health System, you're accountable for the health outcomes of the people of X counties, the creativity and talent of the university would be unleashed in a way that people can't even imagine now. But right now, if you tried to take that as your measure, you would turn the health system from a profit center for the university into a massive losing center. And we're going to have to fix that if we're going to make this happen. I'll mention one other, I got to mention one other way, and you know, this gets a little tricky, but I do think that Google, Alphabet, if it makes explicit the kind of information I've shown you and makes it very easy to use, that it could be that virality could occur in the sense of neighborhoods and communities saying, wait a minute, we're putting all this money into these big monolithic health systems and we're not doing well. So let's change it.
All right. For the reason of time, let's save all the questions to the end and move to the next presentation. Given the broad spectrum of technologies in need, today I want to make a close connection between learning health system and the fast-growing industry, RPA industry, robotic process automation. So next presentation is an industry-focused talk from Duff Glasser from Blue Prism, a leader in the RPA space. Duff is a senior director for North America healthcare at Blue Prism. Previously, he worked with SAP software. Duff, go ahead. Please let me stop my sharing so that you can share your screen.
No problem. I'm not going to do a PowerPoint.
Okay.
So you all don't have to be part of that. I'm just going to have a nice discussion. So thank you very much. And what a great lead in from Robert around a digital backbone. You know, Blue Prism, which is the industry creator for RPA, robotic process automation, started many years ago, 15 years ago. And the whole idea around robotic process automation at that time was the ability to look at manual tasks and automate them, thusly freeing up the time of that individual so they could focus on more complex tasks and these more menial, repetitive tasks, such as checking the box when you're applying for a mortgage, making sure that all the different indexes are filled in, etc., could be done by a software robot, also known as a chat box, you know, when you're going for customer service, etc. But we've all evolved now. And I would ask everybody on this call, and when I talk to individuals in healthcare, I ask them to think about intelligent automation. And that's the digital backbone for organizations to think about this marriage, this integration, interoperability of both automation, artificial intelligence, and machine learning, and the value that those type of technologies can bring. And at Blue Prism, we take a different perspective when we look at the healthcare market. And as important as the back office to hospitals is, and making sure that claims management is done correctly, and we reduce the amount of claims denials, et cetera. At Blue Prism, we're taking a patient-centric view. And we believe that automation now, the ability to use what we have defined as patient advocates, digital patient advocates, can literally transform the way both the patient user experiences and the provider, the physician user experiences. So if I were to think about the patient journey, and we come up to that virtual door, that portal, and as that patient knocks on that virtual door because they need to schedule a procedure, they're met there by a digital advocate. And that digital advocate makes sure that they pre-register correctly. They make sure that their insurance information is handled correctly. It could be Medicaid, it could be Medicare, it could be commercial, whatever the case is. And then it takes them through that patient journey, making sure that they're scheduled for all of their tests, scheduled for their procedures, and that they're reminded, because that digital patient advocate is communicating with all the different stakeholders inside the continuum of care. And then as that patient has received their care, that patient advocate makes sure that all of the test results, all of the ancillary information is distributed accordingly. So all the different stakeholders in that patient's journey is communicated to in a timely fashion. And then, of course, upon discharge, those discharge orders are communicated and then followed up on and communicated again with the patient. And of course, that the electronic medical record is filled in correctly, and also that the claims information is done correctly, so it's adjudicated correctly. And again, you're looking at how now automation is holding the hand of the patient through that journey. And what this does for the provider, also the physician, is it addresses one of those critical areas right now where learning is so important. Physicians want to spend their time with patients. They don't want to spend their time in front of a screen filling in information and doing data roles, etc. The good news is this isn't a what could be, this is a what is happening now. We're working with organizations today that are looking at how we can address patient care and physician education using automation and using artificial intelligence and using machine learning to make their lives easier. And I know that Robert referred to, you know, better patient experience, but also better physician experience. And these are all part of a bigger puzzle that these new digital backbones, these foundations that are provided by the technology companies such as Blue Prism are providing now for providers and caregivers and organizations, because we're moving from that back office focus to the front office, the clinical integration clinical and back office, that connecting of the dots. And in that way, we look at the whole patient journey, the whole patient experience, the whole provider experience, and how we're able to address it make it more positive. And I always say, and I always end my speeches, is that today's technology has to look at what I call the trinity in healthcare. And the trinity is patient safety, patient satisfaction, and patient outcome. And automation and these platforms today, especially at Blue Prism, is where we are focused. And I want to leave time for question and answers, so I'll scale my discussion back a little, but I wanted to give you that broad brush and give you an idea of where technology, where RPA has morphed from to where it is today as intelligent automation, all the way through the life cycle of the patient. Okay, well, thank you very much for this opportunity.
Great, Jeff. Maybe before we go to the Q&A, I can bring Leo Sonata up from Blue Prism to tell us more about Blue Prism's UK project at the LHS. Leo, could you tell us more about that? Leo is the head of the Health and Life Sciences at Blue Prism. Leo.
Sure. Yeah, so I head up Health and Life Sciences here in the UK. National Health Service, as you probably know, is probably the largest health care organization, employing about 1.3 million people. There's been an analysis done, and I think it was a great introduction by Robert and Duff around digital backbone and the quality of data to give better patient care and a better clinical experience. If I kind of look at sort of the NHS, they worked out about 4.3 billion is spent on the workforce, on the back office and operational administration, right, which equals about 137 FTEs, or 6 to 11% of NHS Trust's budget income, right? A trust being an organization within the NHS. Now, even if you were to average that out at 7% per trust, you're already saving 300 million pounds, money that could be spent on key workers, patient care, and kind of innovation. I think if you kind of look at it from a COVID perspective, one of the things that we see a lot is about being able to release capacity. So if we're able to automate a lot of these processes, using your current existing systems, that has really helped alleviate, pressure on the NHS. So one of the things that is a challenge to, I suppose, being able to get access to care, like what Robert was saying, is that there's a problem with a lot of data silos, a lot of lack of intercommunication of legacy systems, and typically how people have tried to solve it is by throwing people at it to do the intercommunications of different systems and multiple entry, and that creates a lot of inefficiencies. So, for example, if you look at the vaccines that we were talking to, at the very beginning of this call, in the UK, they have a system called NIVS, which is the National Immunization Vaccination System, and the government has kind of told all the organisations to have to enter this data of what vaccine have you had, was it your first jab, second jab, and literally the trusts are taking 20, 30 people out to manually enter this data, which seems like a crazy repetitive thing to do, which at the moment we're automating and accelerating that kind of thing. So I think one of the things, the challenge with regards to digital backbone is that there's so many different systems out there. I think one of the things that Robert was talking about is that, okay, once we have all this data and interconnected, what do we do with it, right? Because obviously from a healthcare system point of view, can they cope? What we are able to do at Blue Prism, and Duff said it very well, was to be able to alleviate that pressure and enable the humans to do what they do best, which is patient care, right? So happy to answer any questions about some of the stuff that we're doing with the NHS. But yeah, we're in about 52 or so trusts now, doing everything from patient engagement to back office stuff to alleviate pressures on the NHS, which at this time they really need.
All right, thanks, Leo.
No problem.
Now let's open up the floor for audience questions. And there are a couple of questions already in the chat. And if you have question, please post it in the chat so I can figure out what order to go through the questions. There's a question about education, patient education, literacy, and maybe I should ask Ed Hammond. Are you there? Could you ask the question directly? He's on mute. Ed Hammond. I will ask, maybe next one is, so he's not there.
I'm ready. I'm sorry, I'm trying to find you, but
okay, great.
Yeah. Thank you very much, Rob. This obviously is a question for you, but health literacy, I mean, we're really pushing things out to patients and everything else, and it seems like health literacy ought to be a major part of that. And digital access, digital health access, I think is important as we go more and more into digital health. We almost, seems to me, is digging the gap deeper and making it wider than otherwise. So how do we accomplish both of those? How do we build that into the system of running health?
Well, I mean, we could talk for days about this, but I mean, the key things to me are, first of all, investment in public education. And I'm hopeful that the new administration, with some of these COVID rescue funds to help the schools get equipped to deal with the pandemic, are going to put infrastructure in that will enhance public education, particularly in rural counties and in urban neighborhoods that are poor, because it's really a two-way street. We need to get information to people, but they also need to be able to receive it. And on the getting information to people, the problem that I'm acutely aware of, both from my FDA experience and now, I certainly don't have any power over search and YouTube, for example, but I get to participate in the discussions about what to do. The health experts don't know how to talk to normal people. And so people say, why don't you give them good information? And we say, okay, let's get Duke and UNC to agree on anything and say it in, at a level that people can understand it. And then we'll be in good shape. But it is really hard to find institutions and entities that are just have an interest in operating at that level. So it's bringing up the educational level, and it's also changing the way that experts talk to patients and the public. And then, you mentioned one thing. I mean, why on earth the U.S. should have these huge areas of blackout for high-speed internet? It's really shameful. And I was shocked, actually. I've been in meetings about these enormous parts of New York City that don't have high-speed internet, not to mention West Virginia and other areas. So I think we need a policy that blankets the country in high-speed internet. And then the last thing is, for a lot of people, they're going to need a community health worker who comes into their home and helps them navigate, because it's also been very educational for me to see the things that people do with what you think are simple instructions. And so, but a little bit of human touch there and getting people into the habit would make a huge difference. So I see that as a big source for employment in rural areas, especially going into homes and helping people figure out how to use their cell phones. Everybody owns one. So we just need to make it more functional.
Thank you.
Great. Yeah, patient education, more efficiently, more effectively is really a key to the learning health system, and how to make it happen. Well, that we will continue to discuss this. Now let's move to the next question. I think Sarah Green asked a question. Sarah, are you there?
Yeah, hi, I'm here, AJ. Hi, everybody. Yeah, I mean, this is, I guess, probably more of a comment, Rob. Your talk was, wonderful and provocative as usual. And I was just thinking about, we have these wonderful tools and wonderful data, and then we have this chasm, right, between where the expertise resides and where the need is greatest. And so I think it's sort of a build on the question that Ed asked and your response is, how do we marry these underserved areas with, persistent low health literacy and lack of resources and these optimal care management strategies? You mentioned that the home inversion of people, wanting to stay in their homes and receive care in their homes, but the workforce just isn't there. And I don't know how many people want to get medical care over a Zoom screen. So I'm just wondering your thoughts about where's the intersection and how do we, sort of get the care to where it's most needed?
Yeah, I mean, I can't emphasize. I mean, Sarah, it's good to hear from you. It's been a while, although I see your tweets fairly often. I come back to the primary thing from my perspective is economics and finance. If we held people accountable and the systems and practices they work for got paid based on improving health outcomes, we would figure this out pretty quickly. And a lot of it, as I said, would have to do with things that you don't need even a nursing education to do well, like take a blood pressure and help people get their medicines organized or deliver, how do you use this app to get the information that you need in a way that you can understand it. So I think, and also believe that we each have some level at which we desire digital interaction versus human interaction. And, that is a spectrum. People like me I'd rather deal with my primary care doc over email with an occasional sharing of an image than I would go in person. There are others who really want to be entirely in person. And we're learning a lot about this in a drug abuse program that we started in, addiction program that we started in Dayton, Ohio, sort of ground zero. When the pandemic hit, it went 100% virtual for obvious reasons. And now that we have some control, what we're seeing is that there really are big differences, and we're sort of exactly halfway when we give people what they want. The real advantage of digital, one of the big advantages for things like chronic disease is you can have very short visits that are very quick and give you tremendous amounts of mutual information in the interaction that you just can't get if you can only see people once a quarter or every 6 months in a clinic visit. On the other hand, people do thrive on being face-to-face with a clinician when they're in distress. So I think we're going to need to characterize everyone about their preferences and then give them what they need. And but it's not going to happen until we change the finances.
Thank you. It's great.
All right. Next question is from Gil Allman. Gilbert, are you there? Gilbert Allman. Sophia. Okay, Gilbert is on.
Rob, I just thought it was a terrific talk as always. I'm interested to hear also how you think the FDA can play a larger role with a new administration. But I think the value-based insurance design and value-based healthcare strategy that you highlighted has already been established with a program led by Mark Fendrick here at Michigan and colleagues now at Harvard. John Ayanian moved here a decade ago. It's a very robust program with programs implemented in many, many states around the country and many businesses. The federal government has been the slowest to pick it up, but I'm hopeful we'll have some progress now. I trust you know Mark Fendrick and colleagues from all your other activities.
Yeah, I think I'll just say a couple of things about it. I mean, I think, first of all, the FDA, I don't think the issue is so much inside the FDA, but it's the handoff from the FDA to the implementation system, CMS, and insurance companies there's a gap in evidence. FDA, is under increasing pressure to put things on the market more quickly based on a, reasonable hunch that it works, but then we don't know what to do with it.
Yeah.
And, this is a matter of law. The public wanted it, and the law tells the FDA to do it. Whether that balance is right or not, I don't know, but there's definitely, even if we went back to the old standards, the kind of trials that are submitted for FDA approval don't tell you about effectiveness in the broader population or about comparative effectiveness, and we really need that information. But so I think it's really the interaction between across FDA, CMS, NIH, and CDC that's critical. And I have to admit, I'm a bit frustrated because I didn't have much time. But I felt like if Francis Collins and me and Andy Slavitt, Tom Friedman had another 4 years, we could have really done some things, because people are surprised when I tell them there are lawyers in each of those agencies who primarily protect that agency against all the other federal agencies. And so they're just like academic centers, there are silos and barriers that have to be overcome. And then on the great programs that you have at Michigan, I think the major deficit is value-based care does really well already when you have selected populations that are relatively well off. But if you make them geographically based, so there is no ability to select, that's still a test that's yet to be done. And I'd say the closest thing to it is actually Medicaid expansion, which is like all the way on the other end. But fundamentally, if you have X number of dollars and you make healthcare available to everyone, I think we now know you can't randomize it, but not only are the health outcomes better, but the economics of the areas get better, which is a pretty big statement.
You may know better, but I think North Carolina has been one of the early implementers of VBID at the state program level.
Yeah, Mandy Cohen, the secretary of HHS, was chief of staff at CMS when I was there working with Andy Slavitt, and she's brilliant, and is really in a state where the legislature is totally opposed to all this stuff. She's managed to win people over, primarily based on the economic argument that this actually improves the economics of the region.
All right, thank you, Gil, for question, and Robert for answering. Because of time that we already reached the top of our, maybe even a couple of minutes past the hour. So we need to wrap up this webinar in a minute. Let's thank for the wonderful speakers again, and also a big thanks to our volunteers. For the next forum, we'll pick up one technology area to focus on. If you are interested in helping organize the forum, please contact us. We need more volunteers in order to continue creating forum programs to engage meaningful and productive conversations. Thank you all for coming, and today's meeting is adjourned. See you next time in 2 months.
Thank you, everybody.
Bye-bye.
Big thanks.
Bye-bye.
Thanks, everyone.